So a lot has been discussed recently regarding the utilization of interventions that either lack evidence or have questionable findings or have inconclusive evidence, whether it be dry needling or ASTIM, cupping, ISTIM, so have you. The narrative that's often provided to rationalize these interventions, and I think some of them carry more weight than others, is, well, the patient asked for it, so I'm going to provide it. The patient's attributing some beneficial effect from this treatment, so that addresses their pain or their symptoms, so I'm going to use it, which I find interesting because if we look at different examples in healthcare, that rationale may not really work too well. Okay, take for example, you have a patient who has a chest cold, common flu. Okay, they go to their provider, PA, physician, NP, and they ask for an antibiotic. And we know, pretty conclusively that an antibiotic, unless you are, immunocompromised or have an adventitious bacterial infection, it's probably not going to be to your best interest. Probably not going to do anything for you, and it's going to drive up healthcare costs. And then we can go on the whole discussion about, bacterial resistance. But anyway, we would view the provider offering this antibiotic or prescribing this antibiotic for a common flu as providing bad care because he's practicing in contrary to the evidence. He's kind of allowing the aims and the whims of the patient to influence his decision despite the evidence and probably his best judgment. Okay. And on the flip side, we would view him as, refusing to deliver the antibiotic as good care. That's what he should do because this is not going to be to the benefit of the patient. There's not a lot of evidence to support it. Another example would be, say, if we had a patient with low back pain. Okay, just pain. It's severe, but it's just pain. They've got normal function of their bowel, bladder, and other systems. It's just pain, and they go to their physician and they're asking for surgery. And we know surgery is usually not indicated for a diagnosis of pain alone. There's a lot of good evidence to support this, that jumping to back surgery, spinal surgery is probably not a good option. We should try other things, and we would expect the physician or surgeon, whoever the person's talking to say, hey, let's try rehabilitation, let's try other things. Surgery is probably not a good option right now. Let's try something else that we got a little bit more support for. And his decision of the provider would be based in the evidence that exists. You would expect him to do these things. And on the flip side, if he goes forward with surgery just because the patient asks for it and that's what he wants, we would view that as bad care. Why did he not try rehabilitation? Why did he not try something that has a little bit more evidence to support what he's doing? And I guess surgery is a little bit different. We'll talk a little bit about that in a bit. Another example is opioid medications. Okay, so a patient comes to a provider for some kind of musculoskeletal issue, or pain, musculoskeletal pain, or so happy is pain, and he asks the provider for an opioid. And we know that opioids have a lot of issues with dependency, and a lot of detrimental physiological effects, especially for side effects that they've been given for long term. It's probably not the best thing to jump to. I mean, this is the whole point of emphasis for the Choose PT campaign. Getting patients away from opioid medications, maybe something a little bit less, aggressive with medication, and getting them into rehabilitation. And we would expect the provider, and for good reason, to say, hey, let's not jump to the opioids despite the patient maybe asking for them or had them before. If you would expect them to say, hey, let's try, rehabilitation. Let's try something a little less aggressive. Let's get you off the opioids. Let's try something different. And on the flip side, if they just doled out the opioids just because the patient wanted it, we would view that as bad care. Now, some of these examples, are a little different than what we might experience in physical therapy, and the consequences, of course, of surgery are a little bit more dire than, providing maybe an ultrasound, in the clinic because the patient asked for it. But think about it conceptually. And Kenny Veneer, the physiological PT, provided a really good blog post on this recently, when he mentioned that, I think a lot of times we jump to these interventions and, don't even think about the consequences because we don't see significant consequences, in the clinic. Like, it's not something we view as significant. But think about it. We're that care, which may not have a lot of support, is still coming at cost. The patient's still paying for it and paying for something that may not really be doing much for them when they could otherwise be doing something a little bit more useful, that has a little bit more support. And then again, I'm not a psychologist. I'm not a psychiatrist. I can't make this determination, but there's been a lot looked at on this concept of dependency and fragility that we may be perseverating by choosing these interventions that patients come for and ask for, these passive interventions. If we're not breaking that line of thought in the patient that they're dependent, that they need these treatments, or that there's some sort of issue that only these things can resolve, we may be facilitating that. We're not breaking that cycle of dependency. So that's something to think about as well. And a lot of times I often see patients say, well, placebo effect, it worked. I think the placebo effect is, it's a powerful thing. It's very powerful, but I think it's kind of overextended to mean more than what it was, and that's a whole separate discussion, which I won't have now. But I think a lot of the centers around, the concept of being that discerning voice in your community. And by that I mean, it's okay to tell patients no. You've spent many years in school and studied, thousands of hours of physiology, biomechanics, of all these things to be that source of evidence, that source of knowledge in your community. Patients aren't coming to you just to, just to kind of go by their aims and whims. They're looking for your advice. They're coming to you with problems that they want you to help solve, not answer to the beck and call. And we'll talk a bit about that scenario a little bit towards the end as well. But take, for example, and I get there's the service aspect. You can't just tell patients no; they may not come back. But take this example from the service industry, which I worked in for 5 years before I started PT. You go to a restaurant, and this happened to me. I worked in a restaurant, and someone orders a combination that's just terrible. That's not going to be something that they're going to enjoy. It's kind of your duty as a waiter, and it was kind of what I would do. It's like, hey, sir, that might not be a great idea, and maybe not in those words, but I would recommend something else based on kind of what their interests are. I would say, hey, I see you're interested in this. You might enjoy this a little bit better. And more often than not, they would kind of take my advice because, well, they realize I work here. I know the menu. I've come across hundreds, 1,000 customers. They would take that advice. And I'm at that point was a college kid. I was not a trained point of authority like a healthcare provider. A doctor of physical therapy. I was just a college kid. And I think more often than not, they would appreciate that versus getting something that's just terrible, and then me not offering that discerning opinion, saying, hey, let's try this option instead. It's kind of like that example with your friends where they're doing something that is kind of ridiculous. Like, say they're running outside in the winter after taking a shower, stark naked. And they injure themselves, they get frostbite or something like that, and they would come to you like, hey man, like, you encouraged us, why didn't you stop me from doing this? And that's just your friend, that's just your friend. This in a certain sense, like you're looked as to having, more expectations because you possess this knowledge, so again, if we're not at least having that conversation saying, hey, I don't think this is a good idea. This is probably not in your best interest. I don't think we're doing our due diligence for our patients. And then consider, like I mentioned before, well, what if the patient, that's what they're going to do. If they want this, they're always going to want this. They're not going to get. They claim, like they're not going to get better. That they'll go somewhere else. Well, consider this too. So if the patient's not going to take your professional opinion on something, what is the likelihood of them following through with their plan of care, or with anything that you're going to do in rehabilitation? Just think about that. So don't be afraid to say, to offer that discerning opinion, or at least have that conversation. And I think that's the issue. We're too complicit with these treatment choices, and allow some of these things to kind of perseverate and become more disseminated within our profession, because we're not at least having that conversation and saying, hey, I understand this has worked for you before. Um, you know, um, this may help with your pain, but let me explain to you what may be actually going on here. Having that conversation, educating our patients. Our patients should be the center of what we do as providers. Um, they should be the focus. But let's make sure that focus is focused. That it's accurate. Going by the aims and whims of our patients. That's not evidence-informed medicine. That's not even medicine. We've got to at least have the conversation. We got to be that educator, that motivator in our communities, that discerning voice, with our patients. And I think at least having the conversation and acknowledging the limits of some of this stuff, it's going to do a lot for our profession moving forward.